Welcome to SEDSConnective webinar. SEDSConnective is the foremost charity for neurodivergence and hypermobility and all the associated conditions. We are user-led, we are voluntary, and we welcome all your support, which we are really, really grateful for, and our advisors and specialists who are giving up their time. I'm going to start to introduce a little bit about Dr. Rabenstein, who was born in Germany, but graduated from an Irish university. He spent most of his working life as working in an NHS hospital as an anaesthetist. His private practice centers on providing intravenous conscious sedation to dental patients who cannot otherwise have their treatment needs met or facing very long and invasive procedures. He is a fellow of the Irish College of Anaesthetics and a member of the Royal College of Anaesthetics and a former council member of the Association of Dental Anaesthetics and Sedationists. I tell you, for someone else that has difficulty pronouncing, that's incredibly difficult for me. And I do have incredible difficulty pronouncing things. He has 30 years experience of explaining planned anesthetic and surgical interventions, reassuring frightened customers and cannulating both adults and children, regardless of how tricky their veins are. He's happy to provide information and insights gained from his practice for the benefit of the public, and anything else he is welcome to disclose. So I am going to now hand over to Dr. Rabenstein, and we will do the slideshow. Thank you so much. And with us is also Alice helping with the presentation. Thank you.
Right. Welcome, everybody. Glad to be here. And I feel right at home in SEDSConnective from the start, I have to say, because I am neurodivergent myself. I was diagnosed at the age of 50 as autistic. And one of the things that makes the world so difficult, especially when you're not well, is if you either have traumatic previous experience of healthcare or have genuinely tricky veins. So this is a common issue and one that the profession of medicine and dentistry really has ignored pretty much for far too long. And in order to lighten up this topic, I have interspersed my presentation with references to movies featuring Steve Martin. So fear and anxiety, especially of dentistry, is a big thing in dental school. It is very common. Varies estimates of the incidence range from between 9 and 35%. A question of definition to some extent. Needle sticks, of course, and the sting of the local anesthetic and the sound of the drill and the feel of the vibration of the drill can be very, very intimidating, even more so to neurodivergent patients. Of course, when we have a toothache, the location of it is so close to where we conceive our innermost being to be in our head, that it's doubly frightening, and the same goes for headache. There are also other factors, such as most patients don't actually have a concept of what to expect in detail at the dentist, what the dentist is going to do in terms of cleaning, spraying water, polishing, drilling, and so on and so forth, and of anatomy and of where these injections of local anesthetic need to go, and so on and so forth. The local anesthetic injections are always really quite horrifically painful, and that are full of which are full of pain sensors, treatment being left incomplete. And you can well imagine that there's some very good dentists out there and some pretty poor ones as well. I wanted to emphasize also that good dental treatment, both from the patient's point of view, looking after their own day-to-day dental care, so brushing, eating well, flossing, and so on and so forth, is extremely important. We've only realized in the last couple of years, really, that the mouth being so full of bacteria, if the balance and composition of the bacteria in the mouth is not right, it actually sets us up for disease everywhere else in the body. And we now believe that a lot of vascular and coronary disease is actually originally linked to poor oral hygiene, dental plaques, and so on and so forth. So it is extremely important to teach the next generation to look after their teeth right from when they're small, as well as to do it ourselves. I should say I come from a family of dentists. My father, grandfather, and uncle were all dentists, and I know it is a struggle to actually do the necessary every day. And my own dental care is not as good as it should be. So I do empathize with those that struggle. So this is one of Steve Martin's relatively early appearances in the movies. So if you've ever seen Little Shop of Horrors, you will remember this scene because it's literally unforgettable. So tricky veins are, of course, the real thing as well. In the hospital, at the GP practice, when you have a blood test, whatever. And the more we are afraid of it, the more adrenalized we are, and our veins get smaller when we are adrenalized. So sort of a bit of a vicious cycle. So it's a common thing. Interestingly, people who have bad veins supposedly one day may have much better veins the next day. So they vary from day to day. They also vary between, for example, identical twins. I have come across identical twins where one had really, really tricky veins and the other one didn't at all. So, and it depends on the experience of the person at the soft end of the needle, and practice makes perfect, or as close to perfect as you can get. So I tend to joke that, it gets easy after the first 10,000, but it definitely does. So dehydration is another effect. So if you know you've been booked to have a blood test, or you are going into the hospital to be treated for something that has made you ill, then it is a good idea to make sure you're not dehydrated. So to drink lots and lots of water, best plain water, or maybe flavored water, but water beforehand. It will definitely help making your veins stand out. So reassurance is crucial. The doctors and nurses and phlebotomists that can actually chat to you, establish a relationship, reassure you, make you maybe laugh a bit, tend to do much better than the ones that treat you as a number or see themselves as a purely technician, not interested in seeing you as a person. There are local anesthetic creams available in every chemist that you can apply beforehand, but you obviously need to have an idea where the veins in question are. So typically on the back of your hand and in your elbow crease, you can apply that beforehand. It needs at least an hour to work, and it needs to be covered by an adhesive cover that makes sure that the cream doesn't just wipe off. So warm limbs are much easier to cannulate or bottomize than cold limbs, and some people genuinely have very, very poor veins in their arms. And in the hospital, we may sometimes have to either have a look at the veins in their feet, or even do the anesthetic thing of putting in venous access somewhere around the neck. It has happened to me. I've put in a number of central venous lines in people that were just too tricky to cannulate anywhere else. And so this is an anesthetist's bread and butter. Bruising is common and generally happens when the vein, the needle perforates the vein, not only from above, but goes right through. So you can see here that 1, 2, and 3 are at different depths from the surface being the skin. And 1, it means that the needle went through the skin, but actually not deep enough to enter the vein. 2 is as it should be, and 3 has gone too far and has perforated both the upper and the lower wall of the vein, often causing, not always, but often causing a bleed and a bruising. And the cannulators or phlebotomists that are inexperienced will take the needle as shown in 3, the attempt, as a fail and just draw it out and give up on that particular attempt. But especially as anesthetists who do a lot of cannulating, we find that actually this, even to me now as a very experienced operator, happens a lot, but generally can be corrected by withdrawing the tip just a little bit, realigning it when it's inside the vein to make it parallel to the skin, and then push it forward. So not giving up on it, realizing that it's gone too deep, but retrieving the situation. The picture on the other side shows typical veins at the back of the hand, and 2 points to be made here in terms of putting a cannula in. It's always best to have a straight run of vein, and especially a Y junction. You can see this is sort of a Y on its head, and the best place to go in is at the junction, at the center point of the Y junction. But you can also see that there's a little bit of a bulge where I've located a venous valve there. All veins have valves because the blood flow is meant to be unidirectional from the periphery back to the heart, and the valves help ensuring that. And if a cannula comes up against the valve, if the tip of the cannula sits right against the valve, then it may look as if it's in the right position, but it may actually not allow blood to be drawn out or fluid and medications to be injected. And if the fluid and medications are injected under pressure, the valve may burst and give a bruise, and that cannula is gone. So that's always to be borne in mind. So this is something I wanted to address because we find that it is just, it looms so large in patients' headspace in particular, but also with dentists and doctors and nurses. Shame and guilt they're just so unhelpful. We are indoctrinated to feel shame and guilt. It's very, very hard to get over that, but it really makes everything a lot worse, because people who strongly feel shame and guilt over it tend to be in denial, tend to miss appointments rather than attend them, not want to talk about it, and so on and so forth. And especially with poor dental state of hygiene and treatment, their teeth may not be visually appealing, and so they may habitually avoid smiling, and that makes just for really a miserable life. So yeah, it's all really to say it is so important that if dental phobia, fear of needles, is a thing that is a barrier to appropriate treatment, then please, please, please try and find ways of addressing that problem, because it is a big problem. And self-loathing is just so negative, so bad, leads to depression, leads to dysfunctional relationships with healthcare providers, with family members, with so many people. Our culture inculcates it, but it is one of the worst things about our culture. So lots of complicating factors. The parent or the dentist tend to basically say this is nothing to worry about, it'll be a walk in the park. And then when things don't go according to plan, trust is just lost completely. This is particularly for children, but also for patients who may have learning difficulties or may have had previous very traumatizing experiences. And so we are very much against these glib blanket reassurances. Similarly with sedation, which is the area that I work a lot in, where the community dentists and the general practice dentists tend to tell their patients, don't worry, you'll be out, you won't know a thing about it. And then we have a really hard job telling the patient, no, that's not strictly speaking true. No, you will not be out. Do not expect to be out. You will be more like pleasantly drunk, but you will hear what's happening in the room. You will see lights on the ceiling. You will feel certain sensations, except you won't care as much about it. So this is a bit of a bee in my bonnet, how important it is for dentists and healthcare professionals to be straight with their patients and to not tell them fairy tale stories beforehand, because it means that, we basically have to readjust the expectations, and that's always a tough gig. So PTSD is both commonly caused by poor healthcare experiences, but also, especially in the context of dental treatment, it needs to be recognized that people attend who already have PTSD from something else and who therefore may really, really struggle to follow commands to sit in the chair, hold still, allow me to inject you, allow me to drill in your mouth and whatever. So one study, I think it was from Dublin, showed that about a third of the attenders in a specialized special care dental unit found that their patients, about a third of them, were survivors of physical or sexual abuse. So that really is a bit of a wake-up call and something to be borne in mind. Neurodivergent patients especially may have sensory issues, of course. So with the sensation of brushing your teeth, your gums, the taste of the toothpaste, whatever, may have ARFID, food intake restrictions issues, and so on and so forth. So I think the more it gradually becomes apparent how many of us are neurodivergent, I think this is the attending issues become a little bit more normalized, and that's a good thing. Whereas until recently, anybody who had these issues was just brushed off as weird and not worth making accommodations for. But of course, those people who really struggle to successfully see a dentist and have dental treatments tend to end up with really advanced dental disease, and ultimately requiring far more invasive treatments, such as having all their teeth pulled and then replaced in some form or fashion. And that is, it's really not the way forward. So to be avoided at all costs, if possible. So coming to Ehlers-Danlos syndrome and connective tissue pathologies. So obviously this is becoming better researched over the years. is also more common than was realized, because there are a lot, similarly as to with neurodivergence, there's a lot of people who have it to a limited or milder extent, who just never get diagnosed because it doesn't seem to be enough of an issue or affect them severely enough to be put through the diagnostic and assessment pathway. But there is a lot of potential problems. The HEDS in particular, is increasingly known to be associated with a relative resistance to local anesthetics, which a lot of dentists are unaware of. And we really don't know why this is, but it is estimated that of patients with a diagnosis of HEDS, about almost 90% of those reached by a questionnaire, by a survey, said that their experience of local anesthetic at the dentist has been that it was essentially inadequate, whereas the same was reported by only a third of patients with no EDS. So which is really to say that even the average ordinary customer that walks into a dentist and gets something done under local anesthetic can expect that local anesthetic to fail to give adequate local anesthesia in up to a third of cases. Quite a lot. Dentists don't like to admit those figures, but with HEDS, it is certainly almost 3 times as much. So it's like 89%. So that may mean that higher doses will work, or it may be that it won't work as long as with non-EDS patients, or it may be that only certain local anesthetics, but not others, work for them. There's a lot more research needs to be done on this, but it's certainly a thing. Yeah, so this is really referring to the loss of control, the loss of agency, the struggling to deal with a situation that's outside of your control. So it helps, I think, to have what's called a grown-up conversation with the healthcare provider that's wielding a needle or a cannula, be that a dentist, be that a doctor, a nurse, whatever. If you know from prior experience that this could be a tricky proposition, then please advise them of that. Make sure they understand how sweaty palmed and shitting bricks you are, because there are things that can be done to increase the chance of success and to make it more bearable for you if they are given a heads up and if they have time to maybe find some extra resources, someone else to assist, a more senior person maybe, and especially maybe point out that you are neurodivergent if you are in fact, and that you find this doubly intimidating for reasons connected with that. So it's best to be on the same page, agree a plan, including a plan B, allocate enough time, and yeah, if necessary, resources and finance. And with kids, certainly always well worth trying to bribe them, as in, when this is done and dusted, we'll go to the ice cream parlor or the toy shop or whatever. Yeah, so these are really a way of saying that things often don't go as planned. Yeah, just be open to that possibility and see to it that the healthcare provider is as well. So myth busting is very important. As I said at the beginning, we are, as neurodivergent people, as people maybe with connective tissue disorders, healthcare providers are not as well informed and educated about these conditions and what comes with them as we would like them to be. So if you have an established relationship with your GP, with your general practice dentist, it is well worth digging down and seeing how much they are aware of, and if they would like to know some more. Yeah, and this is part of advocacy and educating. And as I said, realistic expectations are what it's all about. If the healthcare provider and the patient are not on the same page, it's a recipe for disaster and then for complaints, which every healthcare provider absolutely hates dealing with because they're short enough of time as it is. So the catastrophic thinking reflex is something that really is a thing with mothers, for one thing, but also with people who have already had prior bad experiences. And so it's something that in itself could be addressed, possibly, be it with a counselor, be it with CBT, whatever, because we tend to think that things will just keep repeating themselves, especially when they've gone bad. And that, to be fair, that's not at all necessarily true, especially if you put a bit of effort and advocacy into making sure that there is better information available to the healthcare provider, nothing has been lost in translation, and so on and so forth. So I think, coming back to the fear of the unknown, healthcare providers, clinics, hospital departments, and so on could do a lot better, because those few that do this have really demonstrated that it makes a big difference when they have a YouTube video or similar that walks prospective patients through the procedure they're going to be booked for, so that they know what to expect. And likewise, the healthcare provider that is able to keep a running commentary slightly ahead of them doing it tends to have patients that are better able to tolerate the procedures, unless the patients absolutely do not want to hear that, which is fair enough. But otherwise, dentists and doctors that smile and tell you, so next I'm going to do this and you're going to feel that, and hopefully it should be fine, tend to really do better. And there's an element of sort of slight sort of hypnosis or neuro-linguistic programming that some of the more experienced doctors can incorporate in that, which helps as well. So non-pharmacological approaches is all about setting you up to tolerate the procedure better. So as I said, this can be CBT, this can be just more time available, this can be bringing some of your own stuff with you, and often that's some sort of music player, but could be a comfort toy, could be a blanket, maybe a weighted blanket, could be something to look at and on the ceiling, which I'm going to come back briefly later. And as I said, give the patient as much agency as is practical. So if they feel if their back is starting to hurt from lying flat for too long, that's something that could be addressed by allowing them a 3-minute break. And positive reinforcement is just so powerful. So these are really a reference to how powerful an impact a really smart and obviously gifted an intelligent person can have, which was Steve Martin, the neurosurgeon in The Man with Two Brains, although he overreached himself in the end. But also the 3MUs, classically think they're very smart, but they're not. So it's all about being realistic about how smart you are, and that goes both for the healthcare provider and for the patient. So these are options for procedures, dental, but could be others, could be gastroscopy, could be a colonoscopy, could be look into the lungs by the pulmonary physician, whatever. So often this is only done initially offered under local anesthetic, but often that doesn't go so well because patient is just too finds it too difficult to hold still. There's a gag reflex for gastroscopies and so on and so forth. There's a gag reflex is a big problem in dentistry as well. So something pharmacological to sedate, if not even anesthetize the patient, is planned next. So in sedation, because it's usually done outside of hospital, the patient must remain conscious. So as I said before, we try and make them pleasantly drunk so that they still know where they are and what's happening and why, but are not as fussed about it as they would be if they weren't drunk, or in this case, pharmacologically sedated. So this can be done just by taking like a Valium tablet, for example, which can be prescribed by a GP or a dentist, but that is now sort of frowned upon because there's clearly the danger of the patient coming to the practice already sedated and maybe, having a fall or something before they ever get there, or even in the waiting room, which would be unfortunate and would have to be explained and would have to be dealt with from a risk management point of view. And so yes, it can be done, it can work, but it needs to be, sort of risk management and patient protective procedures need to be in place. Inhalational sedation with nitrous oxide, it can work really well, but just isn't widely available and needs a bit of training for the dental team as well. Intravenous sedation, obviously into cannula, can work well, can even be provided by a dentist using only one drug, but works much better when it's a mixture of drugs given by an anesthetist. And that's sort of my daily bread at the moment. And then there's general anesthesia in hospital that almost always works. But it has to be said that it is next to impossible to get booked for a general anesthetic in the hospital for procedures that are seen as Mickey Mouse, tiny little things. So, for example, cleaning and polishing of teeth, you will not get done in hospital under GA, just isn't ever going to happen. So it needs to be something that the surgeons feel is, proper surgical job. And that can be a big barrier, especially for patients that, for example, have learning difficulties and just really need something fairly pedestrian done. Okay, next slide, please. So this, I said this already. So fillings root canal treatment is generally done very easily, very smoothly under inhalational or intravenous sedation. And then once the patient has had the experience of actually that was fine, then they may hopefully graduate, so to speak, to trying it without the sedation then next time or the time after that. Extractions can be a bit unpredictable, can be very easy, can be horrifically difficult, even for experienced operators. So yeah, and the more there are to be done, the more it becomes sort of major surgery and a lot of post-op pain, which the dentists maybe don't always tell the patient to expect. And then implants is a bread and butter for me as well, and that can be very long procedures, up to 4, 5, 6 hours, which, even though it can theoretically be done without sedation, in practical terms would be almost cruel to do. So that's why we use a lot of sedation there. Next, please. Yeah, so in conclusion, really, I want you to be crystal clear that health is wealth. Nobody appreciates the health that they have until the time when suddenly they haven't got it anymore. It's a bit like youth, as they say, wasted on the young. So have a good look at yourself, your personal situation, your family situation, and think about what your healthcare needs are now and in the foreseeable future. Try to minimize shame and guilt. This is especially difficult for Catholics, I think, being married to one. And then, yeah, just model good coping behavior if at all possible, because kids will take their parents as the lead for how to go about facing healthcare that may not be pleasant in its delivery. If your dentist is not the most educated, maybe in terms of neurodivergence and EDS and whatever else, and is maybe not very flexible in making adjustments that you feel might work for you, then definitely look into changing your dentist. And if you have HEDS, then definitely have a discussion with your dentist and with other healthcare providers that may want to use local anesthetic, because there's definitely a knowledge deficit with some of them. And so this comes from an architecture journal. This was a special article on dental practices, and they had selected, I think it was 9 dental practices internationally that they felt had been done really well in being refurbished or built. So on the right, the dentist working in the patient's mouth there. What I would say is it's brilliant that they have a display monitor on the ceiling, but the color palette in the room, I think, is really far too neutral for my taste, at least, and is, screams out healthcare facility to me. So I'm not sure that that was done as well as it could have been. On the left-hand side, you can see that this bespoke ceiling provides a view for reclined patients during consultations. So what I would say there is the colors, wood and green, are, to my mind, nicer and more interesting than in the other one. But just having empty, almost like drawers, looking down at you, it, to me, immediately said, this is a lost opportunity. Why did they not put a whole lot of interesting items or pictures to look at up there to divert yourself, distract yourself while the dental work is happening? So yeah, I think I would have suggestions for improvement for both of them. Maybe you do as well. So has all this blown your mind, brought down the house? We're going to go onto the Q&As next.
I've got some questions. So, Ben, when you said about was that the root canals, I remember having a root canal done, And the dentist was very cross with me because it took ages. And he said afterwards, really did take ages. I had loads of anesthetic. He said, I can't believe how much work you've cost me. You've got the bendiest roots I've ever seen. So having connective tissue and being bendy, does that mean we have bendy roots for the teeth? Because he was really cross.
Yeah, potentially, maybe, but I think, I mean, there's a whole host of factors in the mix there. Because as I said, even bog standard normal, physiologically normal patients can have local anesthetics fail because the local anesthetic is being injected as close to the nerve as possible. But of course, the nerve is a theoretical construct because the dentist has been taught by a textbook where the nerve should be. But in fact, we know from more detailed research that textbook anatomy only applies in practice in maybe 75% of cases. And I'm not saying there's some people out there that have, are just kind of weirdly designed. What I'm saying is that any particular structure that you look at or aim for, be that a nerve, be that a vein, be that an artery or whatever, is only likely to be sort of running in the location and be configured as the textbooks suggest 75 to 85% of the time. So there's a lot of so-called anatomical variation or normal anatomical variation. And if the nerve that the dentist is aiming at to inject local anesthetic next to just doesn't quite run what the dentist thinks it should be, then the local anesthetic is not going to work. Also, there's a lot of variation in patients, not anatomy, but physiology, in that how they handle drugs like local anesthetics, in the same way that, for example, a lot of people handle alcohol. We tend to sort of assess sort of alcohol consumption in relation to body size or weight. But we all know that there are petite little women that can drink grown men under the table, no problem. And there are also, big, bulky fellas that may actually, not tolerate much alcohol, or may tolerate so much alcohol that you cannot actually make them drunk. So there's a lot of genetic variation. So while most local anesthetics put next to a nerve will do the job, there is actually variation in how long that numbness lasts and how quickly it comes on. And certainly, I know a lot of dentists that just don't give the local anesthetic long enough time to work before they start doing the painful stuff. Yeah. And so that's to be borne in mind as well. And the other thing I would say is that in terms of, teeth with bendy roots are extremely difficult to extract. So this is sort of what I refer to the extractions that can be unexpectedly really, really difficult. I've recently seen one where every single root was pointing in was bent and pointing in a different direction. And that's sort of a little bit like a rock climber's crapon that's really designed to absolutely stay in the crevice that you've put it into, and resist all attempts to pull on it. So to your question, with connective tissue disorders, it could be that the dental roots just have more of a tendency to grow in unexpected directions. but also it is a bit overly simplistic, because when you say bendy, you know, that sort of refers to bendy limbs, fingers, and so on and so forth. That again comes from the covering connective tissue and the muscle tendons being more elastic. So it's not so much, I mean, you know, you have to compare teeth to bone, really. And bone, you know, it's not the bone so much that's bendy, it's the joints and maybe the elastic connective tissue. But certainly, yeah, I don't think studies have properly been done looking, you know, at the answer to your question. But it might well be that people with connective tissue disorders do have teeth that might be more difficult, or alternatively might be more easy to extract.
We've got one about a daughter, slightly different. Why does my daughter with hypermobility have her veins shut down when trying to draw blood? And she's also triggered by the tourniquet.
Okay, so yeah, what I would say there is that, you know, the association with fasting, with a general anesthetic, or until very recently also with certain types of blood tests that had to be done in fasting. We feel as anesthetists very unhelpful and sort of creates more problems than it solves. So I would again advise maybe first check with the provider that they don't totally object to it, but would otherwise advise to really keep themselves hydrated as much as possible. So before general anesthetic, we recommend now that as much water as possible should be drunk until 2 hours prior to the start of the operation. Not just you are allowed to, you are actually positively encouraged to. And you're sort of liable to be told off if you haven't.
That's so different. That's
exactly,
so different.
Exactly. So because that appears on the face of it almost the opposite of what used to be taught.
Yeah.
It's a very difficult change to get through and into people's heads, not only patients, but nurses as well. I think that the purpose of the tourniquet is to make the veins stand out more, be more filled, yeah, by preventing the veins to, or the venous content, the blood, to flow back to the heart, so it stays in the limb. But what a lot of healthcare providers were taught wrongly and continue to do wrongly is they think if a little bit of tightness is good, then a lot of tightness is better. And that's not true at all, because if you do that on a limb and you make the tourniquet extremely tight, you actually cut off the arterial inflow into the limb as well. So the veins actually don't stand out that much more, whereas they stand out most if you just make it a little bit tight. And I always make a point of reassuring, especially kids, that I'm putting this on because it helps me to see the veins and to make this whole thing easier. I tell them it will only be on for about 60 seconds, and then I will take it off. And I tell them it will not be very tight. And I demonstrate to them that it will not be very tight. So I suspect that this child probably had somebody put a tourniquet on and then just with a great flourish make it as tight as humanly possible, and was traumatized by that.
So basically putting more time in at the beginning is actually better outcomes for everybody. Just explain what you're going to do visually.
Why you need to do it, giving even that,
Yeah.
possibly you could say, you could give them the option, you know, if you really can't stand a tourniquet, we can try without. It's less likely to succeed, but if the tourniquet is a big thing and you would like us to, we can try without. Or get mom to use her hands as a tourniquet.
So we have lots of questions about children being terrified of needles, not having operations, even though they've got decayed teeth. I know that was my case. And what can they do?
So as a sedationist that accepts kids as patients, and there's lots of sedationists that won't. I have a tough job because the kids are all usually terrified, and I come at them and I propose to stick a needle in them. That's just not a winning proposition from the start. So what I tend to do is I try and reassure them that it's usually straightforward, and if it isn't, and if they, for example, if they haven't had the benefit of local anesthetic cream, or if the cream was put on but either came off too quickly for it to work, or it turns out to be in the wrong place, I have some fallbacks. So for example, there are some cryo sprays that actually make the surface of the skin numb by freezing it. This is what dermatologists use a lot, for example, when they want to take a mole off. And it works very quickly. It literally freezes the skin almost instantly, and visibly, the skin goes white. But I warn them, if they've told me, yeah, okay, fine, we'll give that a try, I tell them that the frost experience, the coldness, is so intense that some patients find that worse than the actual needle stick. Yeah, so in other words, I make sure that they're not expecting to feel nothing in particular and suddenly, oh my God. Yeah. So realistic expectation. And also it needs a fairly slick operator, cannulator in this case, because the frozen skin is only frozen for about 1.5 seconds before it starts to unfreeze again. So it's very, very quick. It comes on quick, it goes off really quick. So I can't actually fuff about trying to increase a better angle or whatever. I need to be in there. Otherwise, it feels like a normal needle sting. But I offer that as an option. And the other thing that I routinely do with kids is, and I think psychologically it has quite an impact, is that they're brought into the room and told, and they must have this, and they have no say in the matter unless they have a meltdown. No choices, no agency, nothing. So because we have different sizes of cannulas that come in different colors, we use yellow and blue cannulas. The yellow being a little bit smaller than the blue. So the blue is my preferred one because it's stiffer and less likely to fall out in the middle of the procedure. But I have the yellow smaller one to fall back if necessary. If there isn't a vein that's big enough to take a blue cannula, for example. But the kids don't know that, and they're not as easily visibly of different sizes. So I say to the kid, oh, one more thing, you have to make a choice here. Would you like the yellow one or the blue one? And I show them up. And I think it makes a huge psychological difference that suddenly they're being asked to make a decision that's their own. They're given a little bit of agency, a little bit of choice. It's literally even the really horribly intimidated kids that are on the verge of having a meltdown, they sort of gasp a bit and, oh, you're giving me a choice. And they either instantly go for the one or the other because that is the color that they like, or they have a real think about it. And then,
yeah, I mean, that would have been so great in my day with my child. Definitely, it was all very. I felt what's the word, disenfranchised, if you like, as a mother. The child is just, this is what we're going to do. This and not. Yeah.
I,
So
I,
we've got a lot of those. I just feel
the
out of
good
control
old,
as a mother
I
or
think
parent.
the good old days of the like 1990s and early 2000s were very much the bad old days. It's really stuff that is not only no longer acceptable now, but has caused a lot of trauma that's we still have.
Definitely. Yeah, so my child went off needles so much, they wouldn't have anything until they were in their 20s. Nothing,
Yeah,
no
yeah. I mean, the other
vaccinations or
thing is
anything.
that, especially with adults, I think hypnosis could potentially work in some people. Um, you know, and as I said already, there's growing interest in neuro-linguistic programming for doctors, for healthcare providers, which is, you know, is a sort of hypnosis that's very subtle, and can be very effective in experienced hands or mouths.
We've got something about hygienists as well. So I think people with connective differences often, everything costs more money and we need more hygienist appointments because our gums, we have more inflammation. So I presume our gums get more inflamed and that leads to gum disease. So this person is worried about a deep clean and having anesthetics. I think it's the same thing you've probably mentioned. She says, I don't have an issue with anesthetics, but I don't know about a deep clean and how long it will work for the anesthetics, if it's different from a normal filling.
Right. So a couple of things. I actually meant to say earlier, with regards to periodontal disease, there is a specific form of EDS that is based on in its classification on periodontal disease. So that where the main manifestation of the EDS is actually periodontal disease. So that's not common at all, but you know, potentially in the bendy community, as you call it, you know, is something to be considered. The other thing is, as I said, for clean and polish, will not, realistically speaking, will never be done under GA because hospitals will be unwilling to book it. And it's, while there's theoretically service provision in the private hospital sector, realistically speaking, even if you had all the money in the world, yeah, I mean, if you had sort of monopoly money or lottery money or Elon Musk money, yeah, I'm sure you could make it happen. But for, you know, a person, a realistically just well-off person, it would be very difficult to book this in the private sector. I'm not saying it would be impossible, but it would be both very tricky and very expensive. So it can be done under sedation. I have done sedations for patients for clean and polish, and I would absolutely be happy to do that. There are both some dentists and some sedationists who have an aversion to that, saying this is ridiculous. You know, which I think is genuine prejudice, and I just don't support it all. It is clearly, I mean, as a procedure, it is much less both painful in the moment as well as painful afterwards compared to more invasive dentistry. But having said that, for someone who has severe issues with sensations, unpleasant sensations, it doesn't need to be pain that brings them out in a rush. It can be, you know, it can be, as I said, the feel of a drill, even a polishing drill, and the taste of the airbrush stuff that they use. So no, I could easily see that. Sedation should work well for it. but we have to be realistic that the success rate of single drug sedation, as provided by the dentist, even intravenously, or as an inhalational gas, success rate there for people who need sedation is of the order of 75%, meaning failure rate is of the order of 25%. For multi-drug sedation provided by an anesthetist, success rate is more like 95%, failure rate 5%.
When I have bloods taken, my veins disappear. I think you might say that's more fluids or something else, but they wondered if a vein finder is a good idea.
There is technology out there that can help, both ultrasound-based and transillumination-based. I have used them occasionally in the hospital with patients with really tricky veins. They are extremely expensive, and I haven't found they made that much difference. But they have occasionally helped. So the answer is yes, they can occasionally make the difference, but they cost like £8,000 a pop per piece of equipment. So, you know, you really only find them in hospitals. And most of the time I didn't need them. So
I think they'd be quite interesting to use.
So definitely for the deeper veins, that's for sure. The ultrasound for the deeper veins, the transilluminator for the more superficial ones, but neither of them will guarantee success.
So unless anybody's got anything else, I think we've talked enough and used enough of Kai's time. So thank you so much, Kai. And yeah, if there are any questions, just email into general@SEDSConnective.org. And thank you so much. We want to do more of these, definitely. I know a lot of people started asking about epidurals and birth and generals, but maybe that's for another time.
I used to be mainly an obstetric anesthetist, so
well, maybe we'll have you back for a separate one. Thank you so much. And everybody, please, if you want more of these, do support us. We welcome all donations so we can carry on. Thank you. Bye-bye.